So for those of you who don't know what this number is the number of heartbeats you have in your life. Right? It's my job as a heart rhythm doctor to try to maximize those and keep them as regular as one can be. So trying to keep this number of heartbeats regular and normal is a challenge that we face as electrophysiologists. But if you think about it, right, the heart is an incredibly well-orchestrated machine. Right? The heartbeat originates in the upper chambers of the heart, the electrical impulses travel down, and this works that 3 billion times, hopefully every minute of every day for 80-something years. It's an incredibly efficient and durable machine. But we have to recognize that in many cases that may go awry. So in atrial fibrillation, the upper chambers of the heart are beating very, very rapidly, very, very erratically, and this has consequences. Right? We know that many people may feel poorly. They may feel tired, short of breath, dizzy, lightheaded, feel that their chest is coming out of their body. What's also interesting is that many people don't even know they have it. And in some people, the first sign of atrial fibrillation could be a stroke, or heart failure, or some other event with neither the patient nor their physician knowing that they had atrial fibrillation. Well, those who have AFib are not alone, right? There are about 6 to 8 million people that we know about in the United States with atrial fibrillation. And when you raise your hands and you have your friends and family, it's not surprising to me. Because the population is aging, we expect about 16 million people to have AFib by the year 2050. If you're 40 years of age and fortunate enough to live till your 80s, you have about a 1 in 4 chance of developing AFib in your lifetime. And we know that atrial fibrillation is a major cause of stroke. And that's because when you're in atrial fibrillation, the blood pools in the upper chambers. And you can form blood clots in an area of the heart called the left atrial appendage. And what happens is that this blood clot can leave the heart, go up the carotid artery, go into the brain, and occlude a blood vessel causing a stroke. So there are hundreds of thousands of strokes every year due to atrial fibrillation, and of course it's one of the greatest consequences and probably the most feared consequence of the disease. So how do we go about accomplishing that goal, right, of maintaining these billions of heartbeats in a normal range? Well, left on its own, for many of us, that won't occur naturally. Right? Many of us will develop abnormal, slower heart or fast heartbeats in our lifetime. But the key, I would say, is research. And I stole this quote because while this has been said of democracy and sausages, I think research, too, is something that everyone likes, but no one wants to see how it's made. Right? Everyone in this room has benefited from the research in medicine that has come before them. And this is an old slide, but if you look at what it takes to get a medical therapy to the marketplace, on average, 5,000 to 10,000 compounds are screened. Only a small fraction of them enter preclinical testing, and maybe ultimately one of those 5,000 to 10,000 will be an FDA-approved medication. That process takes on average about 16 years, and this paper is from 2001 and quoted $800 million to get a drug to the market. It's probably about double that these days. So let me show you how far we've come in my field, right? Because many people sitting in this room, you recognize the outcomes would have been very different had you been born in a different era. So this, believe it or not, is the first pacemaker. Okay? This device was built in the 1920s. We don't know if it was ever fully used. You'll notice a few things. First of all, it was huge, right? There was no way of implanting a device inside someone's body in the 1920s. The other thing you'll notice is that there's a wire coming from it with a handle. And if I would blow this up closely, you would notice that there's a needle coming out of that handle. They recognized that they did not know how to get the heart that stopped moving again, but that if you touch the heart, it would generate a heartbeat. So this needle would be used to plunge through the chest and into the heart. And this handle that you see would be cranked up and allow the heartbeat to go for 6 or 7 minutes. Well, actually, this technology was all but forgotten about until the 1950s, when this doctor working in Boston recognized the need for developing a device that can prevent life-threatening slow heartbeats. So this is what a pacemaker looked like in 1958. You'll notice a few things. Number one, the nurses wore funny hats. Number two, the pacemaker was so big it had to be wheeled on a cart in front of you. The wires went from the device into your body, and it was plugged in to the wall. Right, that's what a pacemaker looked like in 1958. Of course, today's pacemakers are about the size of a silver dollar. are put in an hour or so with leads in the atrium and the ventricle. The device is put in typically underneath the collarbone. And today's devices can be remotely accessed from home, where the device constantly downloads to a bedside transponder. And no matter where you are, we can see what's going on with the rhythm of your heart. Well, when I say that this is today's pacemaker, I'm not totally telling the truth, because this is today's pacemaker. Right? The modern pacemaker is now about the size of a bullet. And actually, it's implanted directly in the heart without leads going into the chest and without the need for a can underneath the collarbone. Now, they're in its relative early phases. These are commercially available. Why don't we put them in everyone? Well, right now, they're only designed to go in one chamber of the heart, the bottom chamber. And remember that first slide that I showed you, the heart should beat in a coordinated manner. But it's only a matter of time where two of these will be placed within the heart. They will communicate with one another through Bluetooth technology, and there will be no leads in the blood vessels. This is the inventor of the cardiac monitor. You may have heard of the Holter monitor. This is Norman Holter. Right? Norman was not a physician, he was a tinker. And he was interested in designing a device that could record the rhythm of the heart outside the hospital setting. The good news is that Norman was successful in his quest. The bad news is the device weighed 85 pounds, you see it here. It could record the heartbeat for 24 hours, and I'm not sure whether the bike came with it or not. This is the modern monitor. This device is the size of a paper clip. Is injected underneath the skin, continually monitors the rhythm of the heart 24 hours a day, 7 days a week for 3 years, and transmits that data remotely through a bedside transponder no matter where you are in this world. So we have come a very long way, but clearly many people in this room represent the successes of this really very successful history, and I know too that many people in this room represent the failures. As a physician, I have to tell you, I tend to forget about the successes. I tend to focus on the failures, right? Because we all go into this field to help people, and sometimes when our knowledge base or tools or understandings and mechanisms become limited, we fail in our quest. And for many of us, that is a very hard lesson that keeps us literally awake at night. We are trying to change that. We are trying to establish the first AFib Translational Research Center at Northwestern, really trying to leverage the talent that's already there. We have an incredibly strong clinical program, as I'll talk about in a moment. We have really brilliant basic physiologists and researchers. And we have people who have the ability to take these discoveries in the basic science environment and bring them into the clinical arena. Now, I must tell you that we already have lots and lots of faculty who are spread out throughout the campus, who work typically in silos, and we try very hard to integrate what we're doing. We have Rishi Arora, who many of you know is an electrophysiologist working on gene therapy for atrial fibrillation. Al George is the chairman of pharmacology, working for new antiarrhythmic drugs. Phil Greenland and Don Lloyd-Jones are the former and current chairman of the Department of Preventive Medicine, really world experts on the epidemiology of atrial fibrillation. Dan Kim is a PhD in MRIs. We stole him from Utah, and I'll show you some of his work in a moment. Brad Knight is the clinical director of EP. Mike Markle, amazing PhD, again in radiology and MRI. Jason Eng is an expert in signal processing. He takes those recordings that we take from within the heart during our procedures and finds new ways to analyze them. Andy Wasserstrom is an expert in calcium handling. We know that calcium handling plays an important role in arrhythmias. And Beth McNally is an MD PhD and a world expert on the genetics of cardiac disease, particularly cardiac arrhythmias. So let me show you where we've been. When I first got to Northwestern in 1998, ablation for atrial fibrillation didn't exist. It was first described actually in Bordeaux, France, late that year. And in early 1999, we started doing it here. Well, you might ask, how does something new happen, right? How do you read an article and then do it on a person? And let me tell you, it's not easy. Thankfully, that person didn't ask, how many of these have you done? But actually, the first cases took us about 14 hours each. About 3 hours of X-ray time, so imagine the radiation exposure. And it stayed that way for quite a long time because we did not have the tools or the technology or even the understanding of physiology to understand how to do this. So what we would do in those days is take 2 catheters, put them in the left atrium, and trying to electrically eliminate the source of atrial fibrillation where we thought it was coming from. About 4 years ago, we were early adopters of this other technology called cryoballoon, shown on the right. What we do there, instead of burning the tissue, we pass a catheter through the blood vessels into the heart. That catheter actually is a balloon that inflates. We push that balloon up against the area that we want to eliminate the electrical signals. We pump frozen fluid through that balloon. It freezes to minus 50 degrees centigrade. We then thaw the balloon. It's like sticking your tongue against a metal pole in the winter. We have to wait till it thaws. We then deflate the balloon and move on to the next blood vessel. When we use this technique, and we've done about 850 cases so far using this new technique, we've taken a 14-hour procedure. We got it down to about 5 hours when we were ecstatic, and now it takes about 90 minutes start to finish with much lower complication rates, much higher success rates, and I think both patients and physicians are happy. But I have to tell you that there's still so much that we do not understand about the mechanisms of atrial fibrillation. We're pretty good at dealing with the kind of AFib that comes and goes on its own, but for people who have been in atrial fibrillation for a long time, changes occur in the heart. Chambers get enlarged. Alterations occur in the ion channels that allow potassium and calcium to migrate in and out. And for those people, we struggle. Now, we know, too, that for many people, blood thinners have been a life-saving intervention, right? Anticoagulation, and you see these commercials, are among the most successful treatments in all of medicine. They reduce the most feared consequence of AFib, stroke, by about 70%. But we also have to recognize that they have risks, and those risks are bleeding. And for some people, those risks are so great that they need to be on a blood thinner to prevent the stroke, but they can't be on a blood thinner because of the risk of bleeding. So let me show you some of the other, I think, fascinating things that we do. I mentioned Mike Merkel. He's actually very, very well known in the field, and he invented this technique called 4-dimensional MRI. This is the flow of blood in the atrium in people with atrial fibrillation. Right? We ask why these people have strokes. Well, I told you that the blood can pool. What we're learning that it doesn't pool the same in all patients, right? And it pools even in patients that don't have atrial fibrillation. So we're trying to understand, does this get better in people in whom we get them and keep them in a normal rhythm? Are there people who are walking around who have this abnormal flow, right, who are at risk of stroke even in the absence of atrial fibrillation? And can we predict who's going to have a stroke on an MRI scan done well before that? Now, this is a very qualitative assessment, but we now have ways to quantify this. So if you have a yellow, green, blue mechanism shown on the upper right, that's normal flow. But people who have a red flow is very sluggish, very chaotic. So we can not only look at it in a very qualitative manner, we can actually quantify how robust your blood flow is in your atrium just by doing an MRI scan. So as I said, 20 years ago, there was no such thing as an AFib ablation. At that time, we had 5 drugs to control the heart rhythm that only worked maybe half the time. We always had medications to control the rate, like a beta blocker or calcium channel blocker. There was a medication called digitalis, discovered in 1774, that we were still using, literally. And there was one blood thinner since the 1940s called Coumadin, right, which was actually originally approved as rat poison. And when it was found to be unsafe for rats, it was then approved for use in humans. So where did the inspiration come from? As a clinician, I will tell you that my greatest inspiration, as I said, comes from my patients. Right? The patients that I take care of every day, you do mean a lot to me, right? And I really do desperately want to help you, and I think we all feel that way. I think while I have many inspirations, I have to tell you, for this particular project I'm going to talk about, this inspiration comes from 2004. At the time, this gentleman was a 70-year-old male lawyer. I tell you that because I think that being a lawyer is a risk factor for things happening to you in the hospital. And just by observation. And at the time, he had high blood pressure and diabetes. He had very difficult to control atrial fibrillation. I had him on drugs to control the rhythm of the heart and Coumadin. All of his symptoms resolved. Every monitor that I did showed that he stayed in a normal rhythm. But our guidelines then and now say that we never stop the blood thinner. Because, as I'll show you, AFib could come back, right? AFib could be asymptomatic, and the first sign of it coming back could be a stroke. So I kept him on his blood thinner until he came in with his intracranial hemorrhage. I still see him today. He is wheelchair bound. He never practiced again. He's severely dysarthric. He has a 24-hour caregiver, and this ruined the lives of himself and his family. So why did I not stop it? Well, I said today, then, and as I say now, that we do not have cures for atrial fibrillation. We just don't. Even open heart surgery doesn't cure everyone. And I don't know how much AFib one needs to have a stroke. So even if I took him from someone in AFib every day and turn him into someone with an hour or two once a week, is that enough to say your risk of stroke is actually lower? We also have to recognize that patients often don't know when they're in AFib. It's estimated that about 40% of patients are completely asymptomatic, and that patients who feel their episodes, on average, maybe feel 10%. So a patient telling me that they no longer have AFib may not be enough evidence for me to base a clinical decision upon. Number 4 is I had no way of thinning someone's blood, right, with a pill. Coumadin takes 4 or 5 days to work, as you may know. There was no pill that would acutely anticoagulate you. And I had no way of monitoring someone 24 hours a day, 7 days a week for years on end if they're sitting across this room or across the world. So while I ruminated over this case for several years, 2 important developments happened. In 2009, a company released a device, an implantable device that can actually record all episodes of atrial fibrillation and transmit it remotely from home. Okay? A year later, the first new blood thinner came on the market in the last 60 years. Right, a drug called Pradaxa, which would thin the blood in an hour. So I said, if we could combine these two, right, perhaps we could change this very challenging and important aspect of the treatment of AFib. The first thing we did is recognize that those chips are valuable in other areas. Right? We know that many patients who have strokes leave the hospital with no diagnosis. They do a lot of tests, and they label these patients as having what's called a cryptogenic stroke, meaning that we haven't figured it out. Well, as an electrophysiologist, this was a no-brainer. If AFib can cause stroke, if AFib could come and go, and if AFib could be silent, how much of these cryptogenic strokes are really due to AFib? So we actually wrote a proposal, did a study where we put these chips in patients with cryptogenic stroke, and what we found was that at the end of 3 years, about 30% of these patients had atrial fibrillation that they didn't know about. And the patients who got routine care, they only found AFib in 3%. This actually got into the New England Journal of Medicine, and this was a pretty big deal, but the question became, my interest wasn't in diagnosing atrial fibrillation, it was really managing atrial fibrillation. So how do you go from seeing a sick patient to coming up with an idea of maybe changing medicine, right, to making that a reality? Well, Bernard Fisher was a famous oncologist, and he said, in God we trust, all others must have data. And we were very, very fortunate enough, I said, to have Julie and a lot of very kind and generous people donate to the Zoe Foundation. And we took a small donation and we developed a clinical study, which we then submitted to the NIH and to industry, and we turned essentially a $15,000 grant into $900,000. And the study that we did was a pilot study of 60 patients using that technology to limit the exposure to blood thinners. Instead of being on it 100% of the time, you would only be on the blood thinner if you had an episode of AFib and would only be on it for a few weeks. So for example, this patient on the left has an implantable device in. This is the amount of atrial fibrillation in minutes per day over 14 months. This patient has not 1 minute of atrial fibrillation. Why are they taking a drug that exposes them to risk with none of the benefit? The patient on the right had a single 6-hour episode of atrial fibrillation. We treated him with a month of anticoagulation, and he was off the blood thinners the other 11 months out of the year. So I mentioned our goal was to take patients who would have been on blood thinner 100% of the time, reduce that to 70% of the time, and we would have declared victory. And what we found was that we could reduce the time on a blood thinner to 6% of the time. Wow. Now there was a lot of excitement about this, and actually, right, when the publisher of a magazine asked the president of the American Heart Association, what's exciting in cardiology, the president of the AHA said, speak to Dr. Passman. I will tell you that that magazine was Popular Mechanics, I am the only cardiac electrophysiologist published in Popular Mechanics. So they published this article about what we were doing, and they interviewed me, and this is my favorite quote. The reporter said to me, well, what did you invent here? Right? I mean, the chip is available, the blood thinners are available, and I responded, I didn't invent the chocolate. I didn't invent the peanut butter. I invented the peanut butter. Sorry about the spelling. Now, I must tell you that this idea was picked up by the maker of the chip, and we were on the cusp of a major trial. But there were obvious hurdles. This was not scalable. The cost of that chip to implant and to follow was about $30,000 to $40,000 a patient. The information only went one way, from the patient to my nurses, and we would have to work weekends and holidays to follow every patient every day. This was not going to be generalizable to the average person living far from a place like Northwestern. So this collapsed about a year ago when funding, which got to about $100 million, was suddenly evaporated. Now, many of you know I'm a big fan of mobile technology. There are devices out there that you can either snap onto your smartphone or simply download an app that will tell you whether you're having atrial fibrillation or not. The problem with that is that unless you're my 16-year-old daughter, no one walks around holding their phone all the time. Right? We need something that continually records the rhythm of the heart and tells that patient that they're having atrial fibrillation, even if the patient doesn't know they're having atrial fibrillation. So the answer to that is this, right? An Apple Watch. An Apple Watch can tell you what your heart rate is, how irregular your heart is, and what your level of activity is doing. So we have teamed up with Apple and another company called Cardia to help develop an artificially intelligent watch that learns you. It will learn what normal is for you. It will learn what abnormal is for you. And if the watch senses that you have an abnormal rhythm, it will do this. This is me and my watch. So the first thing you'll see is my voice when I speak. The white occurs. I can say, Dr. Passman, I'm recording my ECG because I'm having palpitations. It can immediately go to the cloud, and no matter where you are in the world, I can see what your rhythm is and what your symptom is. Once I record it, it analyzes it right in front of me, and it will tell me whether it's normal or atrial fibrillation, and there's my EKG. So, how do we go from that to a wide-scale study? Well, first of all, we need to prove that the watch does what I think it could do. So, we went to Apple and AliveCor. We got 25 watches that we modified, and we gave those watches to 25 patients who have a little chip in place. And we have about 42,000 hours of data that we're now analyzing. I show you one patient here. This is a 14-hour episode of AFib on a $40,000 implantable chip. This is that same episode of atrial fibrillation on a $300 Apple Watch. So we are in the midst of planning a pivotal trial with the help of Apple, AliveCor, and hopefully the National Institute of Health. The goal, of course, is to maintain stroke protection while reducing the risk of bleeding. Now, I must tell you that we've faced many, many hurdles even to get to this point. It's taken a great deal of commitment. Well, I will tell you that many in my field think that allowing patients like you, right, to test themselves and treat themselves is crazy. Right? The thought of going on and off a blood thinner, allowing you to do it, is, as the New York Times says, outlandish. Actually, this was not written in the year 2017 in response to what I am doing. This was written in the 1930s in response to this medication. So I think that the future is unbelievably bright. Yogi Berra, of course, said it's tough to make predictions, especially about the future. But our hope is to make Northwestern the preeminent place in the country, not only for the care of patients with atrial fibrillation, but new ideas. My thought is that many of you come to Northwestern not because you can get the same care at a local hospital, right? Because you come here so that we push the envelope. Right? We are the ones who will be forging new therapies, new treatments, so that not only you could benefit, but maybe the next generation. So with that, I want to thank you very, very much for your attention and open it up to any questions.